Distinguished future physicians, welcome to Stomp on Step 1, the only free video series that helps you study more efficiently by focusing on the highest yield material. I'm Brian McDaniel, and I will be your guide on this journey through anxiety disorders. This is the third video in my playlist covering psychiatry, and we're going to review things like generalized anxiety disorder, PTSD, phobias, and panic attacks. Anxiety is uncontrolled fear, nervousness, and/or worry about trivial or non-existent things. It is an unpleasant fear of future events that are unlikely to occur. Some patients have insight and realize that their uneasiness is illogical, but that does not alleviate symptoms. A certain level of anxiety is considered normal in many situations, but frequent anxiety or anxiety that inhibits function is pathologic. During anxiety, sympathetic nervous system activation can result in physical symptoms such as palpitations, tachycardia, shortness of breath, muscle tension, restlessness, lack of focus, sweating or chills, and changes in sleeping patterns. In order to make a diagnosis of anxiety, one must rule out other potential causes of these symptoms. The differential diagnosis for anxiety includes other psychiatric disorders, cardiac abnormalities such as myocardial infarction or valvular disease, endocrine disorders like hypothyroidism, and respiratory disease such as asthma or pulmonary embolism. Substances such as street drugs and prescribed medications must also be ruled out as potential causes of these symptoms. We're going to hold off on discussing most of the different treatment options for anxiety until a later video that will cover all of the pharmacology for the psychiatry section. That video will cover things like SSRIs, anxiolytics, and cognitive behavioral therapy, which can be used to treat anxiety disorders. However, during the video I will mention a couple of treatment options that are used for specific anxiety disorders. We will start our discussion with generalized anxiety disorder, or GAD. You can see here in the top right corner, I give GAD a high yield rating of 2. For those of you who aren't familiar with the high yield rating, it is a scale from 0 to 10 that gives you an estimate for how important each topic is for the USMLE Step 1 Medical Board exam. GAD is a prolonged period of near constant anxiety. Their anxiety is not linked to a specific item, person, or situation, so it isn't a phobia. They usually worry about a wide variety of things, including school or work performance, finances, health, friends, and/or family members. Their anxiety is generalized across many situations. Their anxiety frequently presents with physical symptoms and may be severe enough to impair function. A panic attack is a sudden onset period of extremely intense anxiety, accompanied by numerous signs and symptoms of anxiety. The attack is often associated with a sense of impending doom. These episodes usually last 10 to 30 minutes and are disabling. The patient returns to their normal level of function soon after the panic attack. They may be brought on by an inciting event or be completely unprovoked. I'd like to stop here for a moment to clarify the difference between generalized anxiety disorder and a panic attack. GAD can be thought of as a constant, moderate level of anxiety, while panic attacks are short periods of severe anxiety. Panic disorder is recurrent panic attacks that are unprovoked and have no identifiable trigger. The onset of these anxiety episodes is unpredictable. Patients may be relatively asymptomatic between attacks, but often have anxiety about having more attacks. Their fear is related to the panic attacks themselves rather than a particular external stimuli. This differentiates panic disorder from panic attacks that are caused by things like phobias. Agoraphobia is anxiety related to open spaces and/or crowded places. These people are afraid of being helpless or embarrassed in a situation that is difficult to escape from. This often leads to avoidance of such experiences, and in severe cases, these people never leave their homes. Agoraphobia is most closely related to panic disorder. In this situation, patients fear having an unexpected panic attack in a place where they may be embarrassed in front of others or help may not be available. However, agoraphobia can be the result of other psychiatric disorders such as specific phobia. Specific phobia is an excessive amount of anxiety related to a specific situation or item that interferes with function. Common examples include fear of heights, spiders, or medical injections. These individuals can be relatively asymptomatic in the absence of exposure to what they fear. Some individuals will adapt quite well, and you won't even know they have a phobia because they are good at avoiding the exposure. For example, somebody afraid of heights may move to an area with no mountains or high-rise buildings. Specific phobia can lead to a panic attack. However, these attacks only occur as a result of exposure to what they fear. They will not have panic attack in the absence of external stimuli. This differentiates it from panic disorder, where the individual will have unprovoked panic attacks. In extreme cases, specific phobia can lead to agoraphobia. For example, if somebody is deathly afraid of spiders, they may never want to leave their house. Treatment can include exposure therapy. Here, the patient creates a hierarchy of fears and is exposed to them in order of increasing level of fear. So a person who is afraid of heights will start with standing on a step stool and then slowly work their way up to using an elevator and going to the top of a skyscraper. By taking baby steps, patients are often able to do things that they would never have been able to do without the process. In certain situations, benzos may be used if the feared stimuli is infrequent and unavoidable. For example, somebody who is afraid of flying but only takes a few flights a year may be well controlled with benzos on an as-needed basis. Social anxiety disorder, aka social phobia, is anxiety in social situations such as public speaking, eating in public, or using public restrooms. This usually includes an intense fear of scrutiny and judgment from others. These patients may be relatively asymptomatic if they can avoid being the center of attention. Social phobia can be thought of as a specific phobia where the fear is related to social situations. However, despite the similarities, the two disorders are separate diagnoses in the DSM. In extreme cases, social anxiety disorder can lead to panic attacks. Beta blockers are sometimes used on an as-needed basis for performance anxiety or stage fright. For example, if a person has to give a big presentation, you can give a beta blocker about 30 minutes before the meeting in order to block some of the sympathetic signals. They still have anxiety, but because the physical symptoms of anxiety are blunted, they won't realize they are anxious. Obsessive compulsive disorder is anxiety and intrusive thoughts that drive the patient to unusual, repetitive actions called compulsions. The compulsions temporarily relieve the anxiety in some patients, while others feel like they just have to do their rituals. Common compulsions include counting their steps, repetitively washing hands, preoccupation with certain numbers, and rituals such as opening and closing doors repetitively. The patient often realizes that their fears and compulsions are irrational, but there remains a lack of control. OCD should not be confused with the similar sounding obsessive compulsive personality disorder, OCPD. There are some similarities between the two, as both can include a preoccupation with things like order, cleanliness, and organization. However, OCPD patients lack the classic compulsions found in OCD. OCD patients also have insight, while OCPD patients do not. In OCD, they view their thoughts and behaviors as abnormal, unwanted, and distressing. In OCPD, they view their way of thinking as normal and beneficial. They don't realize they have a disorder. We will discuss OCPD in much more detail in a later video covering personality disorders. If you'd like to skip ahead to that video, you can click on this orange box here. Post-traumatic stress disorder is anxiety related to a traumatic experience that may include flashbacks, nightmares, and avoidance of certain triggers that remind them of the experience. These patients may also have hyperarousal, where they have an amplified response to external stimuli such as loud noises. Classically, the trauma is experiencing or witnessing a life-threatening event or sexual assault. Symptoms must be present for more than a month in order to make a diagnosis of PTSD. If these same symptoms last for less than a month, the patient would be more correctly diagnosed with acute stress disorder. That brings us to the end of this video. If you found it helpful, please leave a comment below. Feedback from our viewers helps us improve Stomp on Step 1 and rank higher in search results. The next video in the psychiatry section is going to cover malingering, somatoform disorder, and factitious disorder. If you would like to be taken directly to that video, you can click on this black box here. Thank you so much for watching, and good luck with the rest of your studying.